no? So, maternal disorders like diabetes mellitus, maternal infections like syphilis, cytomegalovirus infection, toxoplasmosis, may predispose the baby, the fetus, to holoprosencephaly. So the risk for recurrence in chromosomal abnormality is 2%. And it goes up to 1 to 6% if there is one affected sibling, no? Next slide, please. So, clinical manifestations of a patient with holoprosencephaly. So, there are midline facial abnormalities. So, siguro makita nyo na bala, example, there is ang cyclops bala. No? So, ang cyclops, can you imagine, there is a movie before na may showing the cyclops. So, diba, they have a hypothalamic. So, the eyes are closely spaced, the eyebrows lapitanay, ang mata daw closely opposed, daw lapitanay, there may be left lip, no? Ang nose is has a very flat nasal bridge, no? So there are midline facial deformity. So usually ang defect is at the midline. Kaya di ba there is failure of closure of the anterior midline, no? So that's why na you have midline facial abnormalities kaya wala man siya nag-fully develop, wala siya nag-close mayo. So there may be associated mental retardation, their seizures are frequent, there is spasticity, rigidity, and other endocrine disorders that may be seen in patients with holoprosencephaly. Next slide, please. So diagnostic test or examination. So you may request for a X-ray of the face. You may request for cytogenetics to identify some chromosomal abnormalities that may be associated with holoprosencephaly. You may request for a cranial magnetic resonance imaging, electroencephalography if there is an associated seizures, if there are visual problems because you have midline facial abnormalities. So you may request as well for visual evoked potentials and brainstem auditory evoked potentials. No? Next slide, please. So we go to another disorder of cellular migration and proliferation. So we are now done with the induction disorders na, no, di ba? So the induction disorders happen during the first 4 weeks of gestation. So we go now to the second part, are the disorders of cellular migration and proliferation. So these disorders happen from 1 month to 7 months age of gestation, no? So these disorders develop when neuroblast of the subventricular zone, which forms the walls of the lateral ventricles, fails to reach their intended destination in the cerebral cortex. So pag migrates ang cells, when the cells travel to their intended destination, wala sila kalabot to, na naguba na sila, no? So that is, there is failure now of cellular migration and proliferation. When say proliferation, development, kag nag-multiply sila. So this happened during the first to the 7 months gestation. Next slide, please. So one disorder of cellular migration and proliferation is your schizencephaly, no? So that, for example, you know, ng baluntang your patient has presented with seizures and some facial abnormalities. So you are thinking of a possible schizencephaly. And then the mom will tell you, ay doc, nahulog ko bala sa hagdan, sang lapit na kumabata. So you cannot say na the hulog sa hagdan. You can assure the mom na it was not the cause of the deformity in her child, no? Because you well know that this schizencephaly may happen during the first to the 7 months. So kung nahulog siya on the 9th month of her age of gestation, hindi na siyang possible cause, no? So you can assure the mom para nga madula ang guilty conscience niya. Ang guilt conscience niya, kay mambali siya nga, Ay, kaya wala ko gaandam, nahulog ko sa agdan, so nagamuning bata ko. So if you know the time frame of the occurrence of the disorder, then you may assure the mom and or the parents, no, to that the deformity or the problem happened during that certain time of pregnancy. So schizencephaly is a cleft within the cerebral hemispheres that extend from the cortical surface down to the ventricular cavity. So it is a cleft within the cerebral hemispheres that connect the cortex to the ventricles. No? So nag-connect na siya sa duha ka structures. So the walls of the cleft may be in a position or separated. So kung maghambal ta gani a position, magatapikanay ang cleft, then it is maybe a closed schizencephaly, a closed lip schizencephaly. And if the walls of the cleft are separated and apart, we call it open lip schizencephaly, no? So the walls of the cortex may be normal or it may show areas of polymicrogyria. So ang walls ng cortex ni normal na siya, or there may be an increased number or very small gyri, no? Okay, next slide, please. So pathogenesis, so there is a mutation. So may nag-mutate, no? May diferensya ang homeobox gene EMX2. And it may also be, ang schizencephaly may be a primary or a secondary problem. So ang primary schizencephaly is due to the mutation of the homeobox gene EMX2. Kung acquired problem niya siya, it is due to an encephaloclastic lesion. So there may be something had happened in the mother during this time of pregnancy. Pareho din na there is an hemorrhage, no? May placental hemorrhage, and then it had affected the development of the brain. Or nag-stroke ang mom, that it also affected the fetus. And there may be a vascular event that happened and thus destroying the brain tissues there. So the schizencephaly may be a primary or a secondary problem. So a very important differential diagnosis of schizencephaly is a porencephalic cyst, no? So ang porencephalic cyst is usually caused by a variety of vascular or infectious insults to the brain during late fetal or early infantile life, no? So usually, ang porencephalic cyst results from the dissolution of necrotic regions of the brain, resulting to cavitation and cyst formation within the parenchyma of the cerebral hemispheres. So ang difference nila is, ang schizencephaly communicates with the ventricles of the brain, while the porencephalic cyst or the porencephaly does not communicate with the ventricles of the brain. So it is just a cyst, no? It is a space-occupying lesion that may cause symptoms of increased intracranial pressure, ang porencephalic cyst. So it may cause, while ang schizencephalia, usually it causes seizures, ang porencephalic cyst siya, ang more common manifestations niya are signs of increased intracranial pressure, no? So, but then, okay, next slide, please. So, clinical manifestations niya are variable, no? So, the patient may present with seizures or epilepsy. The brain may be microcephalic, no, or macrocephalic or big. The patient is usually hypotonic or flaccid. There is an associated weakness of the extremities. It may be a hemiparesis or a quadriparesis, and the patient may have also developmental defects, no? Next slide, please. So, another disorder of cellular migration and proliferation is your lissencephaly. When you say lissencephaly, there is a gyria, meaning na there are very few gyri or gyrus, and then pachygyra, very there are uh, s- there are or there is a pachygyria or a macrogyria, dalagpo nga gyri, no? So usually in mesencephaly, we call it the smooth brain. So jutay ang there is a decreased amount of the brain's gyri, no? So this occurs between 12 and 16 weeks gestation. So between 12 is the third to the fourth month of pregnancy, no? So there are two types of mesencephaly, the type 1 and the type 2. So the type 1 is due to point mutation and microdeletion of the L1 SI gene at 17p 13.3 locus. Next slide, please. While the type 2, so you have there, we will discuss the type 2 later. So type 1 mesencephaly is a 4-layered cortex. So we all know that the cortex has 6 layers, di ba? No? So the cortex has 6 layers, while in mesencephaly, there are only 4 layers. So ang clinical picture of a patient with mesencephaly is there is mental retardation, which may be profound. There is marked hypotonia, very severe hypotonia or flaccidity. The seizures may be very common, ang infantile spasms, and the patient is usually microcephalic. No, kay kagagmay sang gyri niya so that the brain did not develop well. No, kay apat na nga cortex ang layer. So the patient is also microcephalic. So the patient may present with seizures. Next slide, please. So ang type 2 mesencephaly, there is almost complete absence of the cortical layering. So ang type 1 mesencephaly, there are 4 cortical layers, while in type 2 mesencephaly, there is almost no cortical layering, no? So ang brain is wala na gid mga sulsay, wala na gyrus, kay very daw isa na siya katipulon, no? So clinical picture may be hydrocephalus, dako yung there is hydrocephalus associated hydrocephalus. There are retinal or ocular malformations, and there may be an associated occipital encephalocele. So type 1 mesencephaly, microcephaly, while type 2 mesencephaly, it's more of hydrocephalus, no? Okay, next slide, please. So another cellular disorder of cellular migration and proliferation is your microcephaly. So when you say microcephaly, it is a small head, no? So the head circumference is more than 2 standard deviation below the mean for age, sex, and race. So you have to know the average head circumference for each race, no? Because ang Filipinos and the Asians are smaller than the Americans and the Europeans. So, syempre, it would follow that our head circumference is also smaller. So that it should be based on the age kag ang sex, no? Kay usually males are larger or bigger than females, no? So dagko ida ulo ang males, and race man, no? So Europeans and Americans are larger than Asians. So microcephaly results from the anomalous development during the first 7 months of gestation. So when it is more of genetic, so it is a primary microcephaly. But it may also be secondary. So if it is secondary to an insult to the developing brain that occurred during the last 2 months of gestation or during the perinatal period. So hindi na siya ha. So ang primary microcephaly, happened during the first 7 months of gestation, while the secondary microcephaly occurred during the last 2 months of gestation or during the perinatal period. So, ang mga very common na cause ng secondary microcephaly is the ng intracranial bleed, no? So parenchymal bleed that is secondary to acquired prothrombin deficiency syndrome, no? So because of the deficient clotting factors in the baby because of the vitamin K deficiency, no? So that there is so that newborns delivered via vaginal delivery and were not given a vitamin K during their delivery period might develop an intracranial bleeding secondary to a vitamin K deficiency or acquired APCD, no? So acquired prothrombin complex deficiency syndrome. So this, because of this intracranial bleeding, the patient will eventually develop a secondary microcephaly. Because of the bleed, there would be eventual brain death and scarring. So if there is scarring, so the brain would not develop, and thus the patient will end up with secondary microcephaly. So that is a very common example of secondary microcephaly. So it happened during the perinatal period, no? So from the last 2 months of pregnancy until the perinatal period. So when you say perinatal, until the delivery, no, the period of delivery. Next slide, please. So the clinical manifestations are very variable, no? So it may range from a very mild impairment of fine motor coordination, medyo daw clumsy lang ang pasyente, or they may be they have a very severe motor deficit, no? Nagatiskog na lang, very spastic, or they are in the cerebrate posture. So gatiskog extended ang all extremities, and spastic all the arms and the legs are in the cerebrate posturing. And ang cognitive function is also variable. So there may be a educable mental retardation, so they can be taught. Also, the mental retardation is just mild, they can be taught, or there may be complete non-responsiveness of the patient because of this microcephaly. And then the patient may be just very hyperactive, no, mild hyperactive, or they may manifest with severe autistic behavior, no, ang patients with microcephalic. So I have patients sometimes nga microcephalic kagagmay, amo ni siya ang I don't know if naabutan nyo na ang magandang gabi bayan ba to sa una before of that were so many years ago na they featured a family with nga monkey daw, no, amo balang itsura. So they featured a family with monkey features, no. So actually those people, those family, kaya ang family have several children, yung gagmay ulo. So those children had microcephaly. So gin-feature ni siya sa TV, kaya do ka abnormal ang sa mga patients. And these patients manifested with severe autistic behavior. So do ang with sila yan, no? So gin-feature na siya sa TV. So actually, hindi na siya. So those are chromosomal abnormalities, no? The example. White naman. Okay, next slide, please. So diagnostic test for microcephaly, we should request for serologic studies, no, to know the cause of the microcephaly. So it may be an infectious process. So common common would be your torch syndrome, no? Or your cytomegalovirus infection. So cytogenetics, so chromosomal, maybe the cause of the microcephaly is chromosomal or a genetic abnormality. You may request for amino acid screening if the possible cause of the microcephaly is metabolic, and you may request for a cranius imaging, no? Preferably magnetic resonance imaging to show the structure of the brain. Next slide, please. So we go now to another deformity is your craniosynostosis, no? So when you say craniosynostosis, it is the premature closure of one or more cranial sutures at birth. So if the baby has an open anterior fontanelle at birth, it is not craniosynostosis. So the anterior fontanelle should be closed at birth for you to say that the patient has craniosynostosis, no? So the defect may be simple or compound. It is simple if only one suture has closed, and if it is compound is several sutures have prematurely closed, no, at birth. So it may also, craniosynostosis may also be a primary problem if it is due to abnormality of the mesenchymal matrix, no? Or it may be secondary if it is due to a mechanical, metabolic, or hematologic disorders that happen during the last few months of gestation. So ang very common example again is the patient with APCD, no? The one I'd mentioned who had an intracranial bleeding upon birth. So that pag-deliver sa iya, there was parenchymal bleeding. So there was brain death. There is scarring in the brain. So the brain did not develop and grow. So there is now microcephaly. So kung nag-develop ang brain, so there is so that it will follow nga ma-close man it would follow that there would be premature closure also of the sutures of the skull. Kaya wala na siya unlagen for development, wala na siya bala wala bala sa may wala sang maano sa iya nga mag-develop siya kay wala man gyud akong brain, so nga di madako ang skull kun ang gamay ang brain. So if the brain is growing, then the skull will also grow, di ba? Kaya nagadako ang brain mo to accommodate. So kung wala gadako ang brain, so that it will follow nga ang skull hindi man mag-grow. So that is a secondary nga craniosynostosis, no? Next slide please. So craniosynostosis may be an isolated phenomenon na siya lang, so it may be primary or part of a dysmorphologic, chromosomal, or a genetic syndrome, no? So ang causes of craniosynostosis may be genetic mutation, so mga chromosomal disorders, no? Ang isa siguro is the ang holoprosencephaly, ito gamay sa ilaulo, no? So it is an example, no? Holoprosencephaly, the patient is usually microcephalic, so sometimes there may be an associated craniosynostosis. So metabolic disorders, some inborn error of metabolism, and hematologic disorders like your intracranial bleed, no, secondary to your hemorrhagic disease of the newborn. Next slide, please. So craniosynostosis occurs in less than 5 in 10,000 births, no? So the anatomic classification will depend on the description of the head contour or depend on the shape of the head or on the suture or sutures involved, no? So let's say it is so you have mga sutures mo, cranial sutures, di ba? You have your coronal sutures at the frontal bone. Then you have your sagittal suture sa middle of your head, and then you have the sagittal, then you have the transverse sutures, and the ano pa nga sutures ng, so if you have there if it is the coronal suture that closes, so if it is the coronal suture that is closed, we call it coronal craniosynostosis, no? If it is sagittal, ang sa center, so we call it sagittal craniosynostosis. If it is the lambdoid suture that closed, we call it lambdoidal craniosynostosis, no? So it depends on the what suture has closed, no? So the growth of the skull is inhibited in a direction at right angles to the closed sutures. So kung ang coronal suture nagsara, so that ang malaba is the kung ang sagittal suture masira, so ang imo nga head growth would be ang imo nga frontal lobe malaba kag ang imo nga posterior lobe, no? So kung ang sagittal suture ang center mo ma-close, temporarily ma-fuse na siya, then the head growth would be at right angles to the closed suture, so that ang ma-increase is the anterior and the posterior brain. So we call it ng scaphocephaly, no? Kung ang sagittal suture masira, we call it scaphocephaly, no? Kung ang both coronal suture masira, so ang ang brain mo ang growth will be on the side, so we call it acrocephaly. Kung isa lang ka coronal suture ang masira, so ang kiwi ang ulo ng pasyente, so we call it plagiocephaly, no? So if only one suture, cranial suture, if only one coronal suture has closed, so abnormal ang shape niya. So ang head contour, ang shape is, so amo na ni ang description, no? So we call it plagiocephalic, kiwi siya. Kung nagpalaba ang sagittal craniosynostosis, daw both shape na siya mo. Naglaba ang front and the occiput and the frontal lobes of the brain nagdako, nag-enlarge. So we call it scaphocephaly, kay daw both shape ang head, no? So amo na siya nga ang description is based on the head contour, no? Okay? Next slide, please. So the clinical manifestations would be either mental retardation or decrease ng intellectual function or cognitive dysfunction, increase intracranial pressure, no? If the sutures if all the sutures have prematurely closed, so the patient may present with increased intracranial pressure signs. There may be psychomotor retardation, and the patient may also present with facial dysmorphic features like hyperteloric, meaning the eyebrows and the eyes are widely apart ng lapad. There may be micrognathia, gamay ang mouth. There may be high arch na palat. Ang mata is shallow or beats, no? Naga-fructose ang eyes or protrude ang orbits ang mata. There may be high forehead, daw lapad ang hagtang, or there may be exophthalmos, nung protrude ang eyes. So actually, what we describe here is the commonly, we call this the Apert syndrome, no? Or the Cusson syndrome, no? Cusson syndrome is a very good example of a chromosomal abnormality with craniosynostosis. So what we have described here is nang kuha na sila mo, they have a boat shape na head. Ang ilang eyes are protruding. Tapos ang ilang nose is big nose, nang gakiwi bala, nang very flat nose, but ang iyang ilong, the nostrils are high. Then nang high arch ang palat, sometimes they have nang cleft lip, no, or palat. And ang very prominent din ang ilang mata, no, so fructose sila eyes. And there is usually the patients will manifest with mental retardation or psychomotor retardation. Next slide, please. So diagnostic tests for patients with craniosynostosis we may request for a cranial CT scan or a cranial MRI. Then management, surgery, no? A question. Surgery is usually done before ideally during the first month, no? After delivery, no? Within the first month or within 6 weeks of delivery. Why? Usually because but usually it is done for not for cosmetic reasons, no? It is for the brain to give room for the brain to grow ang surgery, no? So usually it should not be done just for cosmetic reasons ang surgery, and then it should be done within the first 4 to 6 weeks of life, no? Or 4 to 6 weeks after delivery. Next slide, please. So another disorder of cellular migration and proliferation is the macrocephaly, or a big head. So the head circumference is more than 2 standard deviation than the mean for age, the sex, race, and gestation. So ang macrocephaly, unlike it is not a disease but a syndrome, no? Or it is a primary, it is just a presentation of diverse causes. So pwede siya ba lang, it is just a manifestation ang macrocephaly. So it is not a diagnosis ang macrocephaly, no? So next slide, please. So we have here a table, no, showing you the different causes of a big head, no? So if there is an enlargement of the head from birth up to 6 months of age, the following are considered. So the big head here, the enlargement of the head circumference, or may be due to a hydrocephalus, that may be due to an intrauterine infection. It may be due to a CNS infection, a neonatal meningitis, or no, or it may be secondary to a peri or postnatal hemorrhage, or a tumor or a mass, no? So the hydrocephalus there may be a primary problem or a secondary problem ng hydrocephalus. So the patient may have a congenital hydrocephalus also that may explain the presence of a large head. And then another common cause of macrocephaly is hydranencephaly. So hydranencephaly is a very important differential diagnosis for your congenital hydrocephalus. So in hydranencephaly, usually the head of the infant is very big, no, very large. So usually in more than 50 centimeters, no, and then the sutures are widely apart. The anterior fontanelle may be bulging and widened, no, and the scalp veins are very prominent. So in hydranencephaly, the whole of the skull is filled with cerebrospinal fluid and very small amounts of brain tissues. Unlike in your congenital hydrocephalus, that you have there the brain tissues, but it is just compressed by the very large volume cerebrospinal fluid. Ang imo yang hydranencephaly, you have very small amounts of brain tissues and large amount of cerebrospinal fluid. So that is the main difference between the hydranencephaly and the congenital hydrocephalus. And then the hydrocephalus may also be secondary to an induction disorder, no? So pwede ito lang mga induction disorder mo, di ba? Atong mga cranium bifidum, no? Or ang spina bifida cystica, no? Di ba? Or your other anomalies. And then it may also be the macrocephaly may be also due to a subdural effusion, which may be a problem in the absorption of your cerebrospinal fluid, or it may be secondary to an infection in the CNS, no? So maybe a neonatal meningitis, or pwede ganing neonatal abscesses, no? No, waffle. Next slide, please. So from 6 months to 2 years of age, the common causes of your macrocephaly may be the following. So hydrocephalus again. So enlargement of your ventricles of the brain may be due to a space-occupying lesion or tumors. It may be post-infectious or post-hemorrhagic. And then another cause of your macrocephaly may be your Dandy-Walker syndrome. It may be due to a subdural effusion or to a megalencephaly. So when we say megalencephaly, that is enlargement of the brain tissues and not of the head. So when you say macrocephaly, that is enlargement of the head. Ang megalencephaly is enlargement of the brain tissues. Next slide, please. So in more than 2 years of age, again, the possible causes of your macrocephaly will be hydrocephalus again, secondary to a tumor or any space-occupying lesion, may be cystic or a mass, or it may be secondary to a blood or hemorrhagic, no? It may be post-infectious, or it may be secondary to a Chiari malformation. And then again, megalencephaly or a pseudotumor cerebri. When we say pseudotumor cerebri, meaning there is no, it is a false tumor. So there is no tumor that is causing the increased intracranial pressure or the increasing head circumference. So it is just a condition wherein the manifestations would be that of an increased intracranial pressure. So pseudotumor cerebri may be secondary to uses of steroids, overuse of steroids, overuse of vitamin A, or to or it may be secondary to obesity, no? Tamaan katambok ng morbid na obesity, a patient may manifest with pseudotumor cerebri. Next slide, please. So another disorder of cellular migration and proliferation is your megalencephaly. So in megalencephaly, you have excessive amounts of normal brain constituents, increased amounts of cellular proliferation or storage of metabolites. So pwede na siya yung, ang megalencephaly is due to the increase na ang brain constituents, pwede bala mga supporting brain tissues, no? So you have your microglia, your other brain tissues, not only your neurons, but your other supporting brain tissues like your ng astrocytes, your ng astrocytes or microglial cells, no? And then it may also be to excessive proliferation of the supporting brain tissues, no? Or there may be storage of metabolites, mga abnormal metabolites in the brain. So muna siyang sa in your inborn errors of metabolism, no? There is storage of your glycogen, your mga aryl sulfatase deficiency of your mga enzymes, different enzymes that may cause the deposition of several galactosides in the brain, no? So storage of metabolites. So this is a proliferation disorder of embryonic origin, hamartomatous with occasional malignant transformation. So it is not malignant, no? So it is a benign thing, no? Ang megalencephaly. But occasionally there is a transformation into malignancy. Next slide, please. So clinical manifestations of a patient with megalencephaly. So there may be mental retardation, seizures, hypotonia, mild pyramidal shock and cerebral deficit. So meaning pwede may spasticity, rigidity. There may be problems in the balance, in the gait, and there may be an associated other multiple congenital anomalies, no? Affecting the other parts of the body, not only the brain. Next slide, please. So hydrocephalus. So hydrocephalus is the pathologic increase in the cerebral ventricular volume, no? So it is an imbalance between the formation of the cerebrospinal fluid and its absorption. So kung damo ang formate, if there is any, next slide please. There. So if there is a black, pwede ka, next slide please. O sige nang go back to the previous slide please. So ang pathogen is the cause of the hydrocephalus is there is a blockage in the pathway of the cerebrospinal fluid from the site of its formation to that of its absorption. So the CSF is produced from the choroid plexus in the ventricles, and then it is absorbed in the arachnoid villi, no? So if there is a blockage in any of this pathway, there would be increased cerebrospinal fluid pressure. So the hydrocephalus may be a non-communicating, meaning it is obstructive, if the blockage is within the pathway of the cerebrospinal fluid, and it may be a communicating type of hydrocephalus if the blockage occur after the CSF pathway, no? So, or outside the CSF pathway. Next slide, please. So there are three general causes of hydrocephalus. So there is excessive secretion. So there is only one cause for the excessive secretion of your cerebrospinal fluid, and that is if there is a tumor in the choroid plexus. So the choroid plexus is a vascular structure that produces the cerebrospinal fluid. So if there is a tumor of the choroid plexus, then there would be excessive secretion of your cerebrospinal fluid causing the hydrocephalus. And then another cause of hydrocephalus is obstruction within the ventricular cavity. So there may be a blockage, no, or a stenosis, no, of the aqueduct of Sylvius, no. So if there is a blockage of the aqueduct of Sylvius, then there would be enlargement, no? There would be dilatation of the lateral ventricles and the third ventricles. So you may have the patient may have so the patient will have a enlargement of the frontal horns of the ventricles, no? So that would be an obstructive hydrocephalus, no? So, and then the third cause of hydrocephalus would be a block, no, in the absorption of the cerebrospinal fluid within the subarachnoid space, no? So if there is a block in the absorption within the subarachnoid space, so this happens if there is a intraventricular hemorrhage, no? So if there is a vascular event that happened causing a hemorrhage within the ventricles, so that ang blood there during its lysis, it would form fibrin, no? So it would cause a blockage in the absorption of the cerebrospinal fluid within the subarachnoid space. So that is an absorptive block within the space, no? Or pwede man siya ang mga bacterial meningitis, no? So infectious materials will also cause a blockage in the absorption of cerebrospinal fluid. Next slide, please. So the clinical manifestation of hydrocephalus will depend on the time of onset of the hydrocephalus. So if the blockage happened during intrautero, then pagwa sang baby, there is already an enlargement of the head, no? So may hydrocephalus, so that is congenital hydrocephalus. So if the blockage of the CSF pathway is due to a tumor and the patient is already 5 years old, then the time of onset of the hydrocephalus would be much later, no? So 5 years old na siya. If it is something due to an infectious etiology, like the patient had a meningitis, then the patient may be old enough na to manifest the hydrocephalus. So instead of an enlarging head, ang iyang manifestation would be vomiting, headache, no? Blurring of vision or doubling of vision. So the manifestation would depend on the time of onset. And then also on the duration of the increased ICP. So kung dugay ng iyang if the hydrocephalus is already of long duration, then ang iyang sutures will be gaping, nag-enlarge na yung head, ako na, the anterior fontanelle will be bulging, and the veins would be very visible. So, or kung short lang, and the sutures had already closed, then vomiting na lang, headache, and problem siguro in walking, gait ataxia would be the manifestation. And then it also depends on the rate at which the intracranial pressure increases, and if there is a pre-existing structural lesion. So if the hydrocephalus is due to a tumor, then the patient will also manifest with other signs and symptoms secondary to the tumor and not only due to the hydrocephalus. So kung brainstem tumor ni siya, then the patient will have problems in swallowing, there would be cranial nerve palsies, no? So that will be and several other manifestations of hydrocephalus. Next slide, please. So how to diagnose hydrocephalus? So by measuring getting the head circumference regularly, you can do transillumination of the skull, especially if the anterior fontanelle is still open and the sutures are gaping and widened. So you consider there is lightening no orange color ang skull, and then you may do cranial ultrasonography in small infants where the anterior fontanelle has not closed yet, and then cranial CT scan or MRI in those with older children and adults. So management, surgical correction of the CSF fluid obstruction. So a ventriculoperitoneal shunting may be done. A third ventriculostomy may be done if there is obstruction in the aqueduct of Sylvius, or a tube ventriculostomy may be done. No? A tube is inserted into the ventricles to drain out the cerebrospinal fluid. Next slide, please. So we go now to Dundee-Walker syndrome. So it is a triad, no? So Dundee-Walker syndrome should consist of the following deformities or pathology. So there should be complete or partial agenesis of the cerebellar vermis or the vermis of the cerebellum. There is cystic dilatation of the fourth ventricle, and there is enlargement of the posterior fossa. So these three pathology should be present for you to make a diagnosis of Dundee-Walker syndrome. Next slide, please. So Dundee-Walker syndrome is due to a defect of the closure of the neural tube at the cerebellar level, and this usually occur at 4 weeks age of gestation. So it is an induction disorder, no? And then usually Dundee-Walker syndrome is associated with several anomalies of the brain, no? So there may be associated agenesis of the corpus callosum, stenosis of the aqueduct of Sylvius, there may be an occipital encephalocele, polymicrogyria, and your heterotopias. So I explained those entities already. No, I had explained those entities already. Next slide, please. So the manifestation, so the patient will have a big head, especially at the occiput, no? So when you look at the child, usually the child will have a prominent occiput or occipital part of the head. The patient may present with hypotonia, seizures, and there is mental retardation and the big head. So management is cystoperitoneal shunting. So a tube may be inserted into the cyst to drain the fluid, and it is inserted down in the skin, below the skin, and it will end in the peritoneal cavity, no, to drain the CSF from the cyst in the posterior fossa into the abdominal cavity. And then a ventriculoperitoneal shunt may be also done. I think this is my last slide. Next slide.
Last slide na, Doc.
Oo, sige. Okay, so any questions? Any questions from the audience? So there are so many absent, no? 65 yung kamo. So if there are no questions, thank you for listening and have a cold night.
Thank you, Doc.
Thank you, Doc.
Thank you, Doc.
Thank you, Doc.
Good dog.
Thank you, Doc. Thank you, Doc.